Hello, welcome everyone. My name is Enrico Azurto and I'm one of the parents and researchers that collaborate here at the Autism Research Coalition. Today is a super special day because we have a very special guest with us, Dr. Joanne Kurtzberg. Dr. Kurtzberg, thank you very much for joining us today.
You're welcome. Happy to be here.
Thank you. So first of all, Doctor, on behalf of the autism community, I would really like to start by saying thank you so very much for all the work you do and continue to do for people with autism spectrum disorder and for many other conditions and developmental disorders. I know many families that have greatly benefited from your work, including my own. So we're incredibly appreciative of your work and also for for kindly agreeing to doing this interview with us. So thank you so much.
You're welcome. Happy to be here.
Thank you. So Dr. Kurtzberg has a very impressive and very extensive background, which I'm going to try to summarize in just a couple of paragraphs before we get started, just to introduce her background very briefly. So Dr. Kurtzberg is the Jerome Harris Distinguished Professor of Pediatrics and Professor of Pathology at Duke University School of Medicine. She is the Director of the Marrow Center for Cellular Cures. She's also the Director of the Pediatric Blood and Marrow Transplant Program, and she is also the Director of the Carolinas Cord Blood Bank and the Co-Director of the Stem Cell Transplant Laboratory at Duke University. Dr. Kurtzberg's recent areas of research at the Marrow Center for Cellular Cures, which is funded by the Marcus Foundation, include the use of autologous cord blood in children with neonatal brain injury, also in children with cerebral palsy and children with autism. Her research also includes preclinical studies manufacturing microglial cells from cord blood to treat patients with acquired and genetic brain diseases, and also studies using donor cord blood cells in adults with stroke and children with cerebral palsy and autism. So that's just a very brief introduction to your background, which is very extensive and very impressive. In today's interview, we will be specifically discussing Dr. Kurtzberg's perspective on the recently published results of the phase 2 clinical trial using umbilical cord blood infusions in children with autism spectrum disorder. Last thing I would like to say before we start with the interview, we did receive many questions from parents, which I will be using as space for the interview. So it's possible that if you have any questions, it will be included at some point in the interview. And so without further ado, Doctor, for everyone watching that may not be familiar with the cord blood phase 2 trial for autism, could you please provide a high-level overview of the trial? What were your initial hypotheses and what were you hoping to find?
Sure. So we designed the phase 2 trial based on results we had from a prior phase 1 safety trial, which was called the Duke ABCs trial. And in that trial, we tested whether it was safe to infuse autologous or the child's own cord blood in children with autism. And we embarked on cord blood research in children with autism because we had seen in our transplant program, which is a different approach, that when we transplanted children who happened to have autism as a secondary diagnosis to something like leukemia or lymphoma or a different reason to need a transplant, or in certain children with inherited metabolic diseases where autism was a feature of the diagnosis, that there was some improvement in the autistic symptoms in those children. And we'd also seen in the laboratory that some of the cells from cord blood, particularly a cell called a monocyte, could suppress activation of microglia in experimental systems in the laboratory. And we know that in some patients with autism, microglia, which is a cell in the brain, are activated or irritated, and that could be responsible for some of the symptoms of autism. So after we did the phase 1 trial, which was what we call open label, which means all children got treated. And we saw that infusing autologous cord blood was safe. And then we also saw that particularly in children who had nonverbal IQs of 70 or higher, that there was improvement in some of the symptoms or behaviors associated with autism. And those were measured on several different tests, but in particular, the Vineland Socialization Scale, the Vineland Communication Scale, and then some physiologic tests, which included eye tracking, EEG, and MRI. And I should mention from the start, my colleague in all these studies is Geraldine Dawson, who runs the Autism Center at Duke, and she and her team did all the testing of the children, both to confirm their diagnosis, test their IQ, and then also test all of these outcome measures that we use to look for changes in symptoms or physiologic tests associated with autism. So in the phase 1 study, because we saw some improvement and we knew that these infusions were safe, we embarked on the phase 2 randomized trial, which is really what we're going to talk about today, which is called the Duke X study. And in that study, we randomized children to receive an infusion of cord blood or an infusion of placebo. And the study had a crossover so that 6 months out, the children received a second infusion, and the children that received cord blood the first time received placebo the second time. The children that received placebo the first time received cord blood the second time, and no one knew the order of the infusions that the child received. And the placebo was a pink liquid with the cryopreservative that is used to freeze cells in it. That's called DMSO, and that gives you a bad smell on your breath. So everyone got pink stuff that made their breath smell both times. The study was modeled to answer the question as to whether an infusion of cord blood could improve symptoms, and also eye tracking and EEG and MRI in children with autism. And children who were eligible for the study had to be between the ages of 2 and 7 years of age, which meant not 8. And they could have their own cord blood unit available, or if they didn't have their own cord blood unit available, they could go on to an arm with a donor unit of cord blood that came from our public bank at Duke, and which had to be matched by what are called 4 of 6 HLA types. So it was a partially matched unit. And we equally divided children by age and by type of cord blood they received between both the placebo arm and the cord blood arm. The study was modeled to enroll 180 kids, of which at least 143 would have a nonverbal IQ over 70. But we made what, in retrospect, I think was a strategic error, but we screened kids for IQ remotely because a lot of the kids came from all over the country and were traveling long distances to come for treatment at Duke. And we made a decision to enroll every child that we invited to participate in the study, whether or not their IQ testing actually was confirmed to be above 70 when they came and were tested at Duke. And what turned out to happen was that only 101 of the 180 children had a nonverbal IQ over 70. So we didn't reach that target of 143. And that did compromise some of the analyses of the study. But in summary, we were really trying to ask whether an infusion of cord blood, whether it came from the child themselves or a donor, could improve symptoms of autism 6 months after an infusion.
Yeah, thank you for that summary. So just a basic question, doctor. So in this context, what's the difference between a blood infusion, because that seems like that is very deliberate, in a blood transfusion?
So there actually are 3 words we should probably talk about. So typically when you think of cord blood, you think of a cord blood transplant. But a transplant is a procedure where the cells are given after high doses of chemotherapy. And the intent of a transplant is the donor cells will engraft or live forever in the person who received them. But we made the decision, and I would stick by this decision, that it was not appropriate to give children with autism high-dose chemotherapy. It's very risky. It can threaten their life. There are many complications. And so we weren't testing a transplant. we were testing an infusion of the blood. And to your question, transfusion and an infusion are probably the same thing. The cells are given through an IV into the blood without any preparation by chemotherapy or other treatment.
Yeah, I would actually like to come back to the transplant question, and because there's certainly a lot to be said about that. But thank you for the answer. I guess one aspect that was critical in the study is the fact that there was this HLA matching between the donor and the recipient. And I guess some questions that we have received from parents is what was the purpose of the HLA matching, or what would be the potential consequences of the donated cord blood not being HLA matched?
So in theory, infusing HLA matched or partially matched cord blood should increase the amount of time that that cord blood can survive in the recipient's body. Our immune systems are trained to recognize cells that are not our own through recognition of the HLA typing, which is like a fingerprint of our DNA picture on our cells. So and it's been shown, hypothesized that if we matched, we would have the cells survive longer in the blood than if they were mismatched. Also, with matching, you have less of a chance of sensitizing the child who receives the cells against foreign HLA or someone else's HLA, which in the moment doesn't have any significance at all. But later in life, if that particular child needed a kidney transplant or a heart transplant or some other therapy, it could have made them make antibodies against certain HLA types, which would limit the donors they could use in that, future setting.
Mm-hmm. Yeah, that's really interesting, and thank you. I think that really helps to clarify a lot of the questions we received. But for those that are not familiar with the publication, and could you describe a little bit more in detail what were the general published results of the study, and also from your perspective, what were some of the key findings and learnings that you personally had that were not necessarily published? I mean, so maybe there were some individual cases that you saw that it was interesting that may not be necessarily reflected in the published aggregate level figures.
Yeah. So when you design, a scientifically valid clinical trial, you design that trial to answer certain questions, and the primary endpoint or primary question to be answered in our study was whether an infusion of cord blood improved symptoms of autism measured on the Vineland socialization scale in the treated group more than it did in the placebo. And we did not meet that endpoint in this study. So, the pure clinical trialist would say this was a negative study and that cord blood doesn't work. But really, when we dissected the study and looked at subpopulations within the trial, we had several key findings. One is in the whole group, the placebo effect was very high on this test called the Vineland Socialization Scale, which is a parent-reported outcome. That effect was higher in the group of children who were younger and who also had lower nonverbal IQs. So if you remember, we didn't have enough kids with the higher IQ to reach the power we designed the study for. But nonetheless, when we looked at that subset of kids, which was the subset we intended to examine, which was the kids with a nonverbal IQ over 70, then we did see trends towards improvement with cord blood. And when we subsetted that group further and looked at the 4 to 7-year-olds, then we saw some of the tests have statistical significance for the cord blood group improving more than the placebo. And that was specifically in the communication scales, in eye tracking, in the EEG. And I'll just say we're still analyzing the MRI data. So the problem with this study was we didn't get enough kids with the phenotype we intended, but in that group, even though there was a smaller number, we did see the outcome that or the answer to the question we were trying to ask, which was, in that group, did cord blood improve symptoms of autism? And it did. But where we are now, knowing that, is we still have to do another study and be more careful and judicious about enrolling kids with an IQ over 70 so that we really can definitively answer the question in that group of children. And we have an ongoing study right now using cord tissue MSCs where we've defined the eligibility as children 4 to 7 with an IQ over 70, but the IQ is measured at Duke. And we are planning to do additional cord blood studies for the same reason. I'll also say that we had, many anecdotes from parents about how their children improved or not, but we heard many compelling stories. There were many families who guessed, I guess, what the order of their children's infusion was and when they actually got the cord blood. And the vast majority of those families that I heard from were correct. So they really saw improvements in their children, in their behavior of their children after the real cord blood infusion. And many of those improvements that were described to me included improvement in ability to focus, pay attention, to attend to school, to have better interactions with classmates, to be able to focus on sort of age-appropriate tasks at home. And many families told us their children were communicating better, either by increasing their vocabulary or the way they actually used the words they had. So, we heard enough compelling stories to believe them, but in the world of clinical trial design and proving an outcome, although those are very compelling, they don't prove your point. So we
Yes.
have to do both.
Yeah, and honestly, that's exactly a reason why we wanted to have this live chat with you, doctor, because we know of many of those success stories, and those may not be necessarily reflected in the aggregate level results of a clinical trial. I would just like to go back very briefly to this point that you made about the placebo that was higher than you would anticipate. So what do you think that was? Are there any hypotheses as to why that happened?
So I think that's a great question, and I don't have all the answers, but I think, and we've thought a lot about this as we're planning additional trials. I think part of the problems were related to the fact that we had 2 to 4-year-olds on the study, and the outcome measures we were using weren't very good to analyze that age group. And also, if you think about it, autistic or typically developing 2 to 4-year-olds do gain many skills during that age range. And so it's hard to separate what would be part of normal development from what is an effect of treatment. So that may be part of the problem. Others in our group talked about what's called an expectancy effect. So the hope that your child will get better, can sometimes translate into your child getting better, but not because of the intervention, but because of a change maybe in people's attitude towards that child. But we did see this effect. It was more prominent in the young kids, and it was more prominent in the the intellectually impaired children than the less impaired children. And we're still trying to analyze that.
Yeah. So in these individual cases that you were referring to, that obviously there are some stories that are very compelling and that can give us a hint as to what could be happening, or who could be benefiting the most of these trials. In those there were more noticeable gains, beyond the nonverbal IQ. Was there anything else that could give you a hint as to who could be benefiting most of the the treatment?
So right now I can't say there was anything else, and I'll just mention, we looked at what the other therapies the children were receiving. We looked at any pharmacologic or drug therapies the children were receiving. We looked at the diets the children were on. We asked parents not to make changes in those things over the 6 months of the study period, and I think, based on what parents told us, for the most part, though, there were no changes. So we couldn't see an association really with other therapies or interventions the child was receiving, or diet, or psychological interventions, or school interventions, to the extent that you can say anything about a group of 180 children. We also, I should say, had screened the children for genetic causes of autism. And although I believe there are probably more genetic causes than we're aware of today, the children had to have negative, what's called microarray, and negative Fragile X testing. And the girls had to have negative RETS testing in order to come on the study. And so with the limited data we have, we didn't see any kind of genetic association as well. We looked at things that are known to cause or be associated with autism, like prematurity, infections in utero, older fathers, things that are common in the literature, and we couldn't see associations with those items as well.
Mm-hmm. Yeah. I would like to, with your permission, doctor, I would like to show a very short before and after video of a boy who received a cord blood infusion from a healthy donor as part of your trial. This is a 7-year-old, and we'll watch it. It's only a couple minutes long, and let me pull it up, and we'll be right.
Hysterical. I can't. I know it's hysterical. Just a second. Oh, it's I can't. I know it's. I don't like
Miguel, make yucky faces so we can send them to Omi. Make a yucky face, Miguel. Make a yucky face, Miguel. Miguel, make these yucky funny faces, Miguel. Miguel, listen.
I'm going to switch gears now and talk about our work in children with autism. We first tested, and this is published, the results of autologous cord blood infusions in young children with Autism Spectrum Disorder in a phase 1 trial where our objectives were both to test safety and also to assess endpoints that could be used for a randomized phase 2 clinical trial. There were 25 children with autism enrolled on this study. 80% were male, meaning an IQ was 64, and we assessed the endpoints at both 6 and 12 months for safety and efficacy in this small group of children.
Hi everyone, my name is Michael Besito, and I'm going to play the big piano concert for you. Are you ready? Let's go!
So that is a very, very small part of the video. This is a portion of Michael's what we call recovery journey video from autism. As you might have guessed, Michael is my son. He's 10 years old now, and I personally witnessed his progress before and after the cord blood infusion, which has been tremendous, and that's why I'm so intimately related to the study, and I'm so appreciative of everything you have done. Michael, now he has a Facebook page and that he promotes. He has a YouTube channel. He's very excited about sharing about his story, and and you know, and so we're going to share, you know, some of the resources, so in case people want to see, you know, his journey, as we call it, of recovery. But he's definitely not the only success story. Actually, a couple of parents have also volunteered their information so that I could share it with you today, doctor. So we have another 7-year-old that was 7 years old at the time of the trial. His improvements reported by his mom, are from the trial alone, where that he became fully potty trained. He stopped using pull-ups. He began playing with his sister. He began playing with blocks, trains, and train tracks. He also sought out, you know, to his, you know, parents to get things that he wanted. He increased his speech, and he had less dependence on text, on images, in sign language for communication. We have also the case of a 4-year-old boy that was also part of the phase 2 trial. 1 month post infusion, he began responding to his name, following directions, following simple instructions. He started making spontaneous statements, forming complete sentences, and making requests. He also began noticing objects around him, participating in cooperative play as opposed to parallel play, and started calling kids his friends, and also started acknowledging his sister. He started making consistent eye contact. His OT improved. He was able to feed himself. And that was, you know, a few months after the infusion, and then 5 months after infusion, he was going to the bathroom all by himself. His eye contact was perfected, and he started to engage in play. He was no longer making, you know, articulation errors. That's the way that his friends described this. So a lot of different, you know, gains observed by different people. So which is kind of, you know, part of this, you know, bigger testimony of many people like us, like many families that have witnessed remarkable gains, really. And I guess the other thing that I would like to just you know, highlight for people that are watching us, this was only one infusion, right? So there are other you know, trials that use multiple infusions to assess efficacy. This was only one thing, and just by one infusion, we were able to observe all these different gains that parents are reporting. So after seeing this kind of progress for certain kids, I mean, as you mentioned, it's not all of them. But I guess the question is would you expect cord blood infusions to be approved and made available to general public for the case of autism in the United States at some point?
So let me say that I would hope we can get to a point where they're approved and made available. And that, you know, there are 2 aspects. One is if you use the child's own blood or a sibling's blood, or if you use donor blood. And the FDA regulates those 2 things very differently. But in either case, for better or worse, the FDA considers an infusion of cord blood what they call homologous use for autism, or in our case, we also are doing trials in cerebral palsy and stroke. And so FDA has determined that cord blood's homologous use, or the same use it would have when it came out of the body and goes into another body, is to reconstitute blood cell production after what they call myeloablative therapy. So to use the cord blood like bone marrow in a transplant after chemotherapy or radiation to rescue the blood system. We're trying to argue with the FDA that there can be more than one use of a complex tissue, or in the case of cord blood, a bag of very different kinds of cells. And that we're pretty sure in the cord blood, the benefit of cord blood in autism comes from the monocytes, which is a different cell and not a stem cell, but an immune modulating cell in the cord blood. But in the current regulatory system, because they call it non-homologous use, whether it's the child's own blood or a donor blood, it has to go through the full regulatory process, which includes trials under IND and at least 1 or more phase 3 registration trials, and then an application called a BLA. And I mean, I've gotten BLA for other products we make here, so I know what that process entails, and it's long and arduous and complicated. But the take-home message is, in order to get this approved now, or in our next few years, we have to do a registration trial or another phase 3 randomized trial to prove in a population of kids, and we would target the 4 to 7-year-olds who have the nonverbal IQ over 70 to show definite benefit. That doesn't mean, and I want to be clear about this, that we don't think that some of the lower functioning kids derive benefit. It's just that to design a clinical trial that shows benefit, we have to play to the population that's most likely to give us the answer in the quickest amount of time with the fewest number of patients. So that's why we're focusing on that subgroup that showed benefit in the DUGAC trial. But all I can say is the process through the regulators is quite complicated to get a therapy approved and available under what's called practice of medicine. So you could go to a clinic and get an infusion and have it reimbursed by insurance companies, which is what we hope, but we still have work to do before the people that have to approve it will accept that it really is effective.
Could you please share with us some of the plans that are coming next for the trials that you have in mind? Things that we could do to continue to continue to do research based on the learnings that we have so far.
Sure. Well, so one of the things you said is very important, which is that with cord blood, we're giving a single infusion. And it really isn't impossible from a single cord blood unit to give more than 1 or occasionally 2 infusions, because you have to have a certain number of cells for the dose for the infusion to be effective. So we and others actually are also exploring using a cell called a cord tissue MSC, which can be manufactured from donor umbilical cord tissue, so the actual cord itself. And you can make 500 to 1,000 doses from one cord. And therefore, you could treat many children with many doses. And we've tested that cell in a phase 1 trial, which just got published. And that cell is also safe, not only to give once, but to give multiple times. And we now have a trial that opened just before COVID and was put on hold because of COVID, but will reopen, I hope, in the fall, which is testing whether that cell is effective in children, again, ages 4 to 7, with a nonverbal IQ over 70 with autism. So that trial is funded and open, except it's on hold because of COVID, but should open again soon. We have a smaller trial in babies trying to figure out really how to diagnose autism early, intervene early, and to define better outcome measures for babies than the ones we used in the DUGAC trial. And then we have a small trial funded for adults with autism. So that's 18-year-olds to 35-year-olds. And again, all these trials I'm mentioning now test the cord tissue MSCs. Those are all funded and barring interruptions from COVID proceeding. For the cord blood, we want to do another cord blood trial. We have to get that funded. That is not funded yet, but we believe the results that came from the DUGAC trial are compelling enough to move this forward. So we're working on funding of that trial. And if you said to me what might happen, 5 years down the line, it may be possible that we combine therapies. So a child might get cord blood infusion to start the treatment, but then get cord tissue infusions, every 3 to 6 months to sustain the effect or build on the effect. And that's kind of what we're thinking about now.
Yeah, I would just like to show this graph, which is, I think, very, very important, very telling, and kind of highlights the opportunity, so to speak, right, of what you're referring to here. I mean, this is a comparison between the allogeneic arm versus the autologous arm, and then the allogeneic versus the placebo. And you can see, like, these are odds ratios, which are like, comparisons between the two groups. it is like, I mean, if had this line been a little bit more farther to the right, I guess we would have been in a position to prove that that there was a significant difference, in these two groups. So I think that there is a lot of potential. I mean, from what we have seen so far. So that's absolutely something that we have to highlight. I mean, we were not really that far, right, from demonstrating significance, and that's why it's like so important to continue to push the envelope, so to speak. I guess another question we received, Doctor, is would there be a point where a compassionate care kind of program would be possible for donor umbilical cord blood? We know that there is currently a compassionate care program for autologous, or at least that has happened in the past. But I guess this question is specifically about donor umbilical cord. I mean, what are your thoughts on that?
So from the perspective of regulations, yes, it's totally possible. And right now, it's called expanded access, but we have an IND from the FDA for expanded access therapy for children with autism and other brain injuries using cord blood from themselves or a sibling. And frankly, we could ask the FDA for permission to expand that to allogeneic cord blood or donor cord blood, but we have such a long waiting list at Duke but for the sibling and autologous units and families that we don't have the capacity right now to expand. So even though we could, we would just have a longer waiting list and more frustrated families because we couldn't get them in soon enough. We are working with a few other centers around the country to open up expanded access, and we have opened it up at MD Anderson, and Rutgers is working on opening it up, and we are looking at other options to open some clinics that could provide more access to this therapy without long waiting lists. That is one of our goals and one of the things we're working on. But the reason we haven't opened it up yet is just because we couldn't accommodate the people who would want to come.
Yep. Since there are so many labs in the United States and elsewhere, I guess one question we consistently receive was about your thoughts about the use of other cellular therapies, and you mentioned one of them, like for example with cord tissue, right? MSCs, but there are many others, like from adipose, tissue or bone marrow, or therapies like with exosomes, for example, or others that use a mix of all of these different treatments. I guess the question is, are you familiar with those, and what are your thoughts on that?
Yeah, so the MSCs, which we're making from cord tissue for studies in kids with autism, as you mentioned, can also be manufactured from bone marrow or adipose tissue. And in fact, in other work we do here at Duke, if for completely other indications, we are manufacturing them from bone marrow. But we, because of studies we've done in the laboratory, think that the cord tissue cells are more potent. It's kind of younger is better, and the cord tissue cells come from birthing tissue as opposed to older person's bone marrow or fat. And at least in experiments in the laboratory, they look more effective. And I wouldn't be opposed to studying them, but I seriously don't have the resources to do all types of cells. And so I hope other investigators also come in and study them as well. I have, just to mention, personally given bone marrow derived MSCs to a few children with autism who were getting it for a different reason. And they did have very positive effects on the symptoms of autism. So I think the bone marrow cells will also have activity just from that experience. But just to really accomplish what we are trying to accomplish, which is to get better cellular therapies to the clinic and available for patients, we don't have the machinery or the resources to test all the different kinds of cells. I think though that which now I'm blanking on the word, for the cellular particles from the MSCs. I'm just blanking on the word.
The
exosomes. Yeah, the exosomes are controversial. They are not as, they haven't penetrated the clinic even in research yet as much as the MSCs have. And some people have concerns that you'll remove the active particles when you just kind of collect them from a culture of MSCs that are making them. So because you don't know what's important about what the MSC is making and how to isolate the important factors, you might lose activity if you use the exosomes. And we also know that MSCs work by interacting with macrophages in the body. That's a cell already in your lung and your liver and your spleen and around the brain. And so if you separate out the exosomes, then you may not get the whole part of what the MSC is bringing into the body. And since we don't really know which part is effective right now, in my opinion, I think the MSCs are a better way to go.
For parents that are considering, doing a stem cell therapy for their children, I guess I would just like to ask you as a final question, what would be your recommendations as far as prep work to increase their chances of success? Are there any specific diets, any specific supplements, or safe biomedical treatments that you would recommend to parents?
Yeah, so we've looked at that, and I honestly can't make a recommendation about diet or exercise or sort of safe, off-the-shelf medications or vitamins or supplements. We haven't found any association with any of those things increasing the activity of the either cord blood or MSCs. So no, I cannot.
Thank you. Yeah, doctor, I mean, I really appreciate your time and research. Your research is giving a lot of hope to families, and this is just tremendous. I mean, as you were able to see the progress on Michael, I mean, it's just been absolutely, remarkable. I mean, he's not the same kid, I mean, before and after the trial. So and this is just kind of one example of many, I'm sure. So I hope you give us another interview as we continue to gather more data.
Sure.
and we continue to see more encouraging results. But thank you so much for your time. I mean, we really appreciate it.
You're welcome. Thank you. Take care.
Okay, thank you.
Bye.
See you next time. Bye.